and we might get underway. Now, our thinking was to use the questions that we have here as part of the panel discussion. We have 2 microphones that you'll have to share amongst yourselves, so flicking those back and forward. I'm told if I speak close to this, the echo will stop. There we go. But before I do that, can I just ask the audience if there's any burning question that hasn't been answered for you that you'd first like to put to the panel before we go through this list? I'm seeing... yes. You'll have to ask it because we've got the microphones up here now, so... Can you hear? Okay, I think the first part of the question is about guidelines, so we might stick to that rather than that last little sting in the tail there, if you don't mind, which kind of went off at a bit of a tangent anyway. So, and certainly Nicole and Amanda and perhaps others have had involvement. When you speak, you might, those of you who've been in the plenary podium, you probably don't need to reintroduce themselves, but some of the others perhaps might, just so everybody knows who's speaking. So, but Nicole, if you'd like to kick off on that one.
I regret having the microphone now. Thank you for that question.
It was a plant.
Yeah, the media stuff is really, I think it's a really big problem. It's just my opinion. They're showing a lot of ice use, particularly pipe smoking, and that is not on. A friend of mine actually said to me, they watched the 7:30 report where I said something for about 3 seconds, and they said it made me want to try it. It was like this 50-year-old man who has never used drugs in his life, and said that looks really tempting. And you know, I don't think he actually would, but you know, it for people at risk, it potentially does increase the risk of them trying it or using. I think that is a problem. I thought that there were media guidelines around drug and alcohol, voluntary guidelines around drug and alcohol issues, but they don't seem to be being followed very well at the moment.
Would anyone else on the panel like to comment? Amanda, for instance.
I think media guidelines are a great idea. I haven't seen them if they exist, so it might be something that really needs looking at with the task force recommendations. Yeah.
Sorry, I'll just say one more thing. I think I was privy to some of the Victorian parliamentary inquiry into ICE things. You know, what are they called? Those things. And yeah, people giving evidence. And one of the really interesting things was Melanie Wakefield, she's actually works for the Cancer Council, and she is an expert in mass media campaigns. And what she said to the parliamentary inquiry was that for problems that have a very low prevalence, like methamphetamine use, mass media campaigns are at risk of increasing use rather than reducing use in the community. I think we have to be very, very careful how we present messages to the community about meth use and ice use, because it can alienate people as well.
Just apropos that, oh sorry, Ed, please.
No, she just gave it to me. I had to get it away from her so she didn't talk anymore.
This is like musical chairs, I think, whoever's left with it. But apropos that, then one of the questions on the cards had been, apart from SMS reminders for clients to attend appointments, is there any work underway for therapeutic apps? And so I was using that issue about sort of, you know, guidelines, mass media and other technology as a bit of a segue into other forms of technology such as apps, if anyone wanted to comment on that.
Idea, but I don't know of any.
I agree. Awesome idea.
Awesome idea.
One out for cigarettes
I think there's real scope for apps actually. So, yeah. Yep, there certainly are. Yep. Yep. There's no extra mics. We've got them up here, you see. You'll have to yell. We've done it. Please do. So this is breaking the ice. Everybody heard that? Breaking the ice. So there have been some tentative forays into developing apps, but you'd suggest that it's got more potential?
I think we need to look at adding in some support by either technicians or clinicians to encourage people to keep using it. That was the main problem. Someone said notoriously high dropout rate. Add in online interventions, which also have a notoriously high dropout rate.
Yeah.
Maybe that 50%.
Yeah, absolutely. So,
Can I just
please, Lynn.
just make a
This is Lynn
comment?
Magor-Blatch, for those of you who don't know.
So, yeah, Lynn Magor-Blatch, and particularly from the ATCA, which is the Therapeutic Communities. So one of the things that I just mentioned in the talk that some of you were at was one of the things that we did a couple of weeks ago was just a snapshot across our therapeutic communities to see what the ICE use was like, not actually in the TCs, I should say, but for people coming in, and found very high rates of people coming in. But specifically what I wanted to mention was that around 80%, overall around 75%, but if you look at the youth and the outreach programs as well as the adult TCs, people are saying they've still got friends using. So that puts a whole lot, a big perspective in terms of relapse prevention, the social connectedness, and I think things like apps and online, continue to give people support and so on after they've left a program is really important. So yes, those things I think are growingly important in terms of social connectedness and making sure people have that support once they leave a treatment setting as well.
Please.
Superoni Griffith Pipelines tell us that smoking and IVing the ice has varying effects. Number one, can you tell us more about that? And number two, which is the most destructive way of using it?
As the clinician, everyone's looking at me. Smoking will give you the highest rate of entry of the drug into the bloodstream. There's no question about that. Smoking, if you think about it, is into the lungs, straight through the heart to the brain. If you inject it IV, you've got to go through the heart, round the lungs to get to the brain. So smoking will get it in faster, which is why I think people say that they get the fastest and most intense high.
And is one or the other more destructive than either one?
That doesn't sound like a piece of ethical research. I don't know the answer to that. I think that, they tend, in the same person, they tend to be different populations is the difficulty.
They do, but Rebecca McKean did a bit of work quite a few years ago and showed that the dependence potential from both smoking and injecting are probably about the same. So in terms of dependence, a lot of people think that if you smoke, it's not as bad. But in terms of dependence, it is as bad. But then injecting also comes along with all the injecting risks as well. So all the physical HIV, Hep C harms around it. But smoking can also, come along with those issues as well.
And the respiratory stuff that's coming down the pipe. Our clients tell us that smoking gives them a different fear than injecting. Number one, we see that there's more psychosis presentations
mean, firstly, they're not the same populations, so they're difficult to compare. Secondly, if you're smoking, you can control the dose. You can have a bit and then have another bit and then have another bit. Whereas if you've injected something IV, it's in. So you know, there's all sorts of subtle differences, but the comparisons are difficult because they're not the same populations.
So I disagree with that. In our little bit of research last week, one of the questions we asked, or 3 questions we asked, did you smoke, do you inject, or do you smoke and inject? And actually there were quite a lot of people who do both, who are smoking and injecting. So there's probably that shift, and I think, you know, the things that you're talking about in terms of the effect is really valuable information, because if you're chasing a particular effect, then you might use differently according to that.
Steph, one moment. Steph or Jane, would you like to comment?
Yeah, it's Jane from Harm Reduction Victoria.
I don't think it's
I just wanted to say that from what I see, smoking it is a lot more sociable, and you'll find that people will sit around and just pass the pipe around and around and around, and, you know, in the long run they end up using more than somebody that's just going to have a shot and be with it. You know, people, it's not a real social event having a shot, whereas smoking it is. And I just see the people I see tend to use copious amounts when they smoke, and they just keep on smoking and smoking. And from, you know, people I've spoken to, the bit about psychosis coming more so to people that smoke, I think that might have something to do with just how much they're actually having at the time. So, and as an injector or a smoker, you know, the general rule of thumb is, what do they say, once you whack, you never go back. So if people are going to inject it, they usually won't go back to smoking it, unless it's the social thing and not everyone there knows that they inject, so they'll have a puff on the pipe. And that's not research, that's just from, you know, what I know and people I know.
Okay. On a slightly different tack, we have a question here about how can ice be more or less pure? Ed, you might be a good one for this.
I get that one, do
Yep.
Well, it's fairly simple at one level. I mean, ice is manufactured. It's not manufactured in pharmaceutical laboratories mostly. It tends to be manufactured by amateur chemists, and the end product, it can be a mixture. It can be anything from still having raw materials, having you know, through to very pure methamphetamine, with a whole lot of byproducts, some of which are cardiotoxic, which of course is one of the reasons why people get sick rather than getting high. So the purity varies. The other thing is that methamphetamine itself is an oily liquid, and people want the crystalline form, so it's made into a salt with one or other acid, and the extent to which that occurs will determine purity too. So you may have a sort of gooey mess that is partly crystalline meth and partly still raw methamphetamine as an oily liquid. So purity will depend on a whole lot of things. After all, this is not bought from a pharmaceutical company using the highest of pharmaceutical standards. Yes, well, assuming it's crystals of methamphetamine, not crystals of something else. Yes, it's a crystalline material. And the other thing is, if you look at the international production of the substance, let's say that you have a criminal cartel who managed to produce a ton of white powder. Firstly, there's a limited number of people who have the skill set to move that across national boundaries in a clandestine fashion. Then you get it to your destination, and you want to sell. You've got a ton of white powder, and you want to sell it in milligram quantities. So you've got to have a system of distribution which breaks it down into milligram quantities, into nice little bags. And of course, you can increase your profit if you add other things. What might start off as 99.9% pure crystal meth may be something else on the street, depending upon the honesty of the dealing system.
Please.
On a slightly different topic, do you guys think we'll ever have needle exchange program in prisons? There was a possibility of that happening in Canberra, and that was as we've said, a lot of these, a lot of the drug use or ice use is going to be happening in private, and it's not going to be smoked around in prison. So needles are they're there and they're happening, and prison authorities know that, but no one is really doing anything, and it's probably going to be making things worse in terms of hepatitis and AIDS. So what's going to happen? Is anyone doing something about this?
I might say something. Is there anyone else from the ACT other than me here at the moment who might? Could you repeat the question, please? Well, the question was about whether or not there would be any needle and syringe programs in the prisons. So I'm from the ACT, although not working as the peak body, and I'm not. David McDonald was here before, but is he
Here
gone?
he is, David's at the back there.
David might have some more up-to-date information.
As probably everybody in the room knows, it is official policy of the Australian Capital Territory Government to introduce the needle and syringe program into the Canberra's prison. In recent months, a new agreement has been signed between the government and the Prison Officers Union to establish a new dialogue process, the aim of which is to develop a mutually acceptable model of care for a mutually acceptable model for introducing NSP into the Canberra prison. Note that will not go ahead unless it has the acceptance of more than 50% of the prison officers themselves, not of the union bosses, but of the prison officers themselves. And a group of public health organisations in the ACT, chaired by APSAM, will be working with the Prison Officers Union and the government to assist them in developing that model of care. When that model of the NSP is finalised, that's accepted by the Prison Officers Union, can't be known. But the good news is that there's genuine dialogue and discussion between the government and the prison officers now.
Thanks for that, David. David, are you optimistic that it might happen, if you were to bet on it?
Very cautiously optimistic.
Okay, we'll take that.
6 months ago, it looked like nothing was going to ever happen.
Yeah, okay, thank you very much indeed. I think
I was just going to say you're awesome for raising that issue because it needs to be talked about more, and I'm excited to hear that there's optimism about it, but it's kind of like, why is it taking so long? It's shameful. It seems like a breach of human rights that there are no NSPs in prisons already. We know that they're effective. I believe the statistics are something like if you're a female and you inject drugs and you go into prison, there's a 70% chance that you'll contract a bloodborne virus. And for men, it's close to 50%. So it is shameful that they're not there already.
And of course, they are in some countries overseas.
Thank you. And there's a question right in the back row here. Oh, interesting. On a slightly different tack, so we might after that. On a slightly different tack, this is the $64 million question in some ways. Taking into account frequency trends, what's the general tipping point for developing dependence? And how can this inform early intervention, particularly with regard to ice? So what's the general tipping point for the development of dependence? Open to the panel. You watch that microphone zip down to the end there.
I think Amanda can probably make a comment on this as well, but we think that something more... we think that frequency is associated with dependence. So if you're using more than probably once a week, twice a week, 3-4 times a week, then someone who's using 3 or 4 times a week is very likely to be dependent. Someone who's using once a week is likely to be heading towards dependence.
Yeah, I think it's really got something to do with frequency, and I think conversely, when you're trying to help someone reduce use, it's about obviously reducing frequency. And I think that really helps people get a sense of control again over their use, whether that's, less occasions per day or trying to go a day without use. And that goes, across the drug classes.
There's a terrific book by a woman called Tam Stewart called The Heroin Users, and in it she talks about the pathway and her kind of journey into becoming a really severely dependent heroin user. And answering that question, she said, well, it's a bit like the apocryphal tale of a group of walkers doing a mountain hike, and the goal is to reach this mountain peak. And they get so engrossed in the whole process and conversation and the enjoyment and the views that they go over the peak. And it's not until they've passed the peak and they look back that they realise that they've actually passed the apex. And she said for her, that's what it was like becoming dependent. That you're on a pathway, you're on a trajectory upwards, but you don't realise the point at the tipping point, which is the question: at what point do you become dependent? It's something that you don't realise until it's passed and you look back. So it's a very tricky situation. David, please.
When you think about the theory of the stages of drug epidemics, and think that the research generally shows that when a society starts to get concerned about a particular drug epidemic, inverted commas, we are usually past the peak. I'm wondering, we're on the downward arm of the typical epidemic curve. I'm wondering what panellists think about what stage are we at in Australia at the moment with regards to methamphetamine generally, and crystal particularly, and what are the implications for our interventions of the particular stage in that epidemic curve in which we find ourselves now.
Thank you, David.
I guess I'm not sure I'm going to answer that particular thing, but for me, having been introduced earlier as having worked in the drug and alcohol field for a very long time.
Not that long, really.
And Nicole said, we produce the drug treatment to ice epidemics ago. I think what gets me over the years, I really feel there doesn't seem to be confidence in the drug and alcohol workforce around addressing or just working with mental health problems, and vice versa. I don't know what we can do to alleviate that. We've tried many things. You did SideCheck about 10 years ago, and I think these epidemics, and that just highlight how ill-prepared we are, I think, as a workforce. Even though we've all got the skills, I think because the services are separate, somehow or other we lose confidence that we've got the skills. And I think just about everyone, nurses and psychologists have got the skills, but we don't use them because we belong to different systems. I don't know.
Yes, I agree with that. I think that is an issue. I also can't answer that question, David, but I'll give you my views anyway. I think you're right that often once it's kind of in the media, I think once the Prime Minister started talking about it, it's on the way down probably. And this happened last time as well, kind of reached a peak. The government put a lot of money into it as the problem was becoming less obvious in the media, I think. And I don't know which way around that goes, whether people feel more confident and so there's less media about it because there is some funding going towards it, or whether we've just missed the peak. I'm not sure. But I think that one of the good things out of all the media is that we're seeing a lot more people come into treatment, and I know that's been presented as a terrible thing, and one of the signals that we're in crisis. But actually, I think that's a really good thing that people are coming into treatment in larger numbers, because that's where we want them to be if they need help.
I think a bit like Amanda and Nicole, I can't comment on the curve, but where my optimism lies is that I think there's a shift in what we're doing about it, and increasingly we are starting to see sectors that perhaps have been separate start to work together, and I think that's one of the differences that's occurring now in terms of intervention. So we're starting to see mental health and drug and alcohol work a little more closely together. Clearly I'm biased about working with families, but we're starting to consider that, what are we calling it? And family inclusive practice is more looked at. And so regardless of what's happening with the amount of use and the drug itself, perhaps where the difference might lie here is what we're doing about it.
A related question, which may well have been covered off pretty thoroughly in your session, Ed, is what ideas do the panel have for, to best support people with methamphetamine-induced psychosis in mental health acute settings? And this has been a bit of a theme that's been running through. How do we best manage people, particularly in acute stages of problems, psychosis or otherwise?
I don't work in an acute setting, but does anyone else? Anyone in the audience?
Ed.
Yeah.
The one comment that you would have missed in here was you don't put any services out to competitive tendering and think it's going to improve their... Because certainly what's happened in this state is that it's made it extremely difficult, that the sectors are still trying to work out what's happened to them in the last 12 months, much less work together. And I think what that means is we collectively need to educate policymakers about the need for removing boundaries and having cross-cultural dialogue that is really meaningful between the agencies, because the current system is not designed for that at all.
Okay.
I might just comment from the TCs and the residential program. So I think one of the things that we're seeing is certainly high numbers of people coming in. So the quick survey I did last week showed me that 80% of young people in residential, in the therapeutic communities that we surveyed were there for ice use problems, 63% in our adult populations, and one of the adult populations that we surveyed was a prison setting where there were 80% of the prisoners who were in the therapeutic community in that particular jail had ice use problems. And I think one of the things that we are recognising is that you do have to change. You certainly need to upskill staff. You need to have some awareness and some understanding, and then be able to actually educate people about the changes that are going to happen, so that what's actually happening in the brain, what's actually happening, and how long it will take to pass through, and be part of that and be able to kind of work with that. But certainly a lot of our programs, and so they're not acute. Remember, they're chronic. We're working with people who have a chronic problem, but not necessarily an acute problem. One of the things that the TCs are saying, though, is that someone might have an acute phase, they might have a psychosis, and unfortunately there's not enough working together with services outside, so that someone goes out, maybe has a couple of days in an acute setting and is then able to come back in. There needs to be a lot more of that kind of working together. And our TCs have also had to put on nurses and other people who, have different skill sets to what they've had traditionally in the past. So all of that kind of working together in cooperation with hospitals, with acute settings, and being able to move people backwards and forwards as their needs arise, I think is something that's really important in that.
Okay, thank you. Now, I've got one last specific question, which happens to be for Amanda. They wrote that here, Amanda. Yeah. And then I've got a question which I'll put to each of the panel members, and for you to give maybe 1 or 2 minutes as you wrap up and concluding comments back, and that should take us right up to time at 4:45. Right on time. So, Amanda, why do you advocate for roadside drug testing for methamphetamine? The fact that MA elevates the risk of crash does not mean that roadside drug testing will increase roadside safety.
I'm not sure.
I'm just the messenger here.
Yeah. I'm not sure I fully understand the question.
Is there efficacy for roadside drug testing for meth, do you think?
I think it's about deterring people from driving in the same way. For me, just as a health professional, I think many years ago, before I worked in drug and alcohol, I worked at the Traffic Accident Research Unit, and having drug driver testing, I think, is a really useful thing to do.
Yeah.
Yeah.
Nadine also made the same comment, but Ed, you might like to comment as well, perhaps.
Yeah, I'd love to. There's really, really, really good evidence that the only thing that works in terms of general crime prevention is raising the risk of being caught. You can have whatever penalty you like, but if you're never going to get caught, no one cares. So the huge effectiveness of speed cameras, of random breath testing in changing driver behaviour has been raising the awareness that you may well be caught. And roadside drug testing does that. And it's not about moral judgments about whether people do or don't use drugs. It's a very pragmatic thing that says, if you're going to use drugs, do not drive. It's no different to the message that people get around drinking. And there's a heap of research. It happens to be my pet subject, so anybody wants it, I've got about 2,000 articles. There's a heap of research that says that detection is the ultimate deterrent. So yes, it's worth doing. Right? You don't have to advertise the fact that we don't do much of it. Right? A random breath test costs the population a few cents for a straw and a few moments of time for the police officer. A random drug test costs $50 for the analysis kit and 15 minutes supervision of the driver, and then if that's positive they have to be kept for another 15 minutes for the follow-up test. So it's relatively expensive both in terms of time and consumables, but the message is the important bit.
Roadside drug tests, it's a subject that a lot of people at festivals want information about, and I think that roadside alcohol tests are great. They're great because there's that deterrent, because being caught, I totally agree, that is something that deters people from taking a risk. But with blood alcohol content, it is a fixed reading, and so you can tell, and that reading determines whether or not you're impaired to drive. The issue with roadside drug testing is you are looking only for traces of methamphetamine, amphetamine and THC in the system. So and the issue I think a lot is with THC. If someone is smoking pot on a weekly basis, it may have been days since they last smoked, and then they can get caught.
It won't show. It will not show. The roadside drug test is positive for THC only, and it's positive for 3 or 4 hours max.
I've been in the car with someone when they've been tested positive for methamphetamine, and I've known people, and it's just based on their word, who say that they haven't smoked pot for a week, close to a week, and they're coming positive. So I mean, there's something going on with the roadside drug testing that's not consistent.
Well, I won't argue individual cases, but the research is pretty good. But I'm happy to discuss it with you.
Yeah, I would love to see your research.
Later.
And endless controversy in this area. Okay, I'll take one last comment from the audience before we move to the final panel wrap-up and comment. So.
Well, look, I just make, Dave Taylor from Nevada, I'll make a very quick comment on drug driving. Generally what happens when you increase the quantity of booze busters and drug busters, you're going to catch more people, which then puts more demand onto either drink driver education or drug driver education. Within Victoria, I think there's about 5 providers, someone will be able to correct me on that, for drug driver education. If we increase the number of people caught and don't increase the number of services which provide that drug driver education, we'll end up getting a bottleneck which will be problematic. So I'm not disputing the deterrent value, but I'm just cautioning that when one starts increasing one part of a particular system, the ancillary services supporting that need to also be commensurately increased.
Yeah, I think that's a really valid point, and that I think we've seen through presentations today that when you exert pressure on various points of the system, if you increase demand, you've got to have commensurate capacity building with that, and that's going to be something that will be a strong message, I think, carried up to funders and to the task force. So thank you for that comment. So let me move to the last wrap-up session then, and if you pass the microphone along to Paula, you can be first cab off the rank if you choose. And just in sort of trying to pull together some of our thinking today, I think it's helpful to wrap up talking about prevention and demand reduction. So one question is, what can we do to increase the focus and strategy development around prevention and demand reduction? And so as your takeaway message for today and for the audience, what would be your best buy for prevention and demand reduction?
Well, I'm here with my family's hat on, and so I'm going to keep that on. I think, given we know that the research from family therapy says that the family is a unit that impacts getting people engaged in treatment, retaining people in treatment, and having people adhere to treatment contracts post-treatment. If I had to leave one thing with you to take away, it's to start expanding your thinking around involving families, and rather than it being an exception, that it starts becoming the rule.
Fantastic, thank you.
My one thing in terms of prevention and harm reduction, well, really, I love treatments, they're the best. So. I think we've got good, effective treatments. Australia has led the world in this. We haven't got the constraints in the American research system where they do these long, involved treatments. We've got good, effective, brief treatments. We've got fabulously trained people. I think the picture's an optimistic one. We just have to feel confident that we can do it.
Thank you. Let me just underscore that. It was a theme that ran very subtly through a couple of presentations about some of the best research, some of the best evidence emanates from Australia in this area. And it's a crushing disappointment to me always that we feel that we must rely on overseas, in code America, American research to give us guiding lights when we actually generate some of the best that's available. Go ahead, go on. I know you want to jump in.
That was my question, and I feel that it's missed the mark so far in the answers because it was around demand reduction, not harm reduction, was my question. So from the prevention angle, before the need for treatments. So that was my question. On the three pillars of harm, which is demand reduction, supply reduction and harm reduction, my question was around what are we doing in terms of demand reduction?
Oh, I don't know if you want me to comment on that. I'm a treatment specialist and I can give you my opinion if you want, but it doesn't matter, you know. I can talk about treatment all day, but in terms of demand reduction, I think poverty, education, working with families, that sort of thing.
Amanda said what I was going to say. So I will think of something different. In answer to your question, I think that treatment is demand reduction. We know that if people go into treatment, that there is a reduction in demand for drugs in the community, and that's what demand reduction is. So it is really important that we invest in treatment, and particularly invest in our treatment workforce, because they're the ones that need to be flexible. It's not just about ICE, you know, whenever the next new thing comes up, we all need to be able to adapt, and we need a confident, flexible workforce to be able to do that. And I think that is the key to good treatment, which is the key to demand reduction.
Thank you. As a treatment specialist, I'd agree, but I think the other thing that we often miss in a specialised setting like this is that the vast majority of interactions with users occur in the community. And we collectively need to do more to empower community health centres, general practices, the people who have the interaction with people early in their drug use career, to educate them and help them to not keep going till they get to the top of the mountain and go over it. So somehow we've got to leverage our expertise to enable more people in the community to do more of what we do with the people who don't need the specialised services.
Now, you'd expect, since I work with the therapeutic communities, that I'm primarily at the tertiary end of treatment. But I think one of the really important things is that we're looking at a coordinated approach, whatever. So, you know, our TCs are also working to a large extent with families. And I I agree with the first comments about families, about family inclusive practice. So, you know, our programs are also bringing in families with children. So the children are in treatment too, so we have a primary prevention role with them. But more importantly, one of the things, I think we do need to shift some money, actually, from policing into the treatment sector and therefore into the demand reduction area as well. I think that's really important. I think it's, whilst we need all of the policing, we certainly need far more in terms of working with people. One of the things that's really effective, and you will get my presentation, I think, that even though only some people saw it, but one of the things that's been really effective, for instance, in New Zealand is whilst there have been a lot of work through the drug courts and drug diversion, what has happened is that only happened once they set up the partnerships with the treatment services. So people coming through drug courts, coming through merit systems, CADAS or credit or whichever system they're coming through, actually those people need to go somewhere. And it's all very well putting money into that area in terms of diverting people into treatment if you don't actually give treatment places. So I think that's where, you know, there has to be a whole lot more work done, and certainly working with the families. While sometimes the families can be seen as part of the problem, nevertheless, families are the people who know their family member best, and working with the whole family. It's like working with someone in school. You work with the whole family, you get better results, and you're doing drug treatment as well.
And for the last word, very appropriately, from Jane and Steph.
Okay, so my take-home message today, actually before I say that, the family thing is awesome, but we've got to remember there's lots of people out there that just don't have that support network because of their drug use or whatever. They're estranged. But my take-home message today would be, don't underestimate the power of peer education, and we just need to do something about the stigma and discrimination that drug users experience that causes them to not want to be open and honest and talk about things, and perhaps let it get to a lot worse than what it would have been had they been able to be open and honest about what they're doing. And it comes within the drug using community as well, like drug users discriminating against other drug users. You know, that drug's worse than this drug, or your way of doing it's worse than this. But yeah, I think stigma and discrimination, we'll see a lot of things change if that starts to break down.
Excellent, thank you.
I was just going to agree with Lynn. I definitely think that money needs to be siphoned. I definitely agree that money needs to be siphoned away from supply reduction to demand reduction, treatment and harm reduction. In regards to demand reduction messages as opposed to harm reduction messages, I would suggest the same thing, which is empirically based evidence. Say the truth. People aren't stupid. If you tell someone not even once and they try it once and it's awesome, they might try it for a few more years and then run into trouble. So, I mean, just tell people the black and the white, and when you don't know something, say it's something we need to do more research on.
Thank you so much. So, look, that brings us to the end of our program today, and I'd like you to join with me to thank all of our panel members, but also thanking everybody in the audience for your wonderful contributions as well.